Thanks for joining us. I'm your host, Raquel Faria. I'm a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I'm joined by Professor Sandra Navarra from the Lupus Academy Steering Committee, who will be providing her expert insights into the management of lupus in low, middle income countries. Sandra, welcome and thank you so much for joining us today.
Thank you for having me, Raquel.
So, actually, this podcast has been chosen to our conversation because during the 13th annual meeting of the Lupus Academy, there was much discussion around your presentation about management lupus in low to middle income countries and all the associated challenges. But before we start discussing this, I would like to highlight to our listeners and remember that the World Bank classifies 135 countries in the world as low to middle income countries. And actually, in these countries, there are 6.7 billion people living, which is actually 84% of the world's population. And knowing that these populations' ancestries and backgrounds are also the ones to have higher incidence and severity of lupus, we will be discussing here today the reality of care of the great majority of lupus patients in the world. So this is huge. And you have been studying this and working on this. Can you please tell us just the 2 or 3 main topics that you think are the most challenging to manage lupus in the low middle income countries, please?
Obviously, it's the financial burden of lupus. And we know that lupus requires medications, requires to be spent on in terms of hospitalizations, follow-up visits, etc. It's also the lack of awareness in low to middle income countries, wherein we have less of the education and patients and people in general and the public in general are more aware of more straightforward diseases like cardiovascular events or diabetes mellitus than lupus, which is such an enigmatic disease and pervades many, many aspects of medicine in general. There's also a shortage of lupus healthcare workforce. And as a consequence, in these countries, we lose now the golden opportunity of early diagnosis and management so that many patients seek medical care late into the disease because of all these factors when irreversible damage like renal failure has already set in.
We're going in more detail in all of these points that you highlighted, but let's start on the financial barriers. This is actually not only for lupus patients. Can you please just go through a little bit on global health in low to middle income countries and the financial barriers, both for patients, their families, and sometimes the carriers also?
Yes, absolutely. You know, lupus is a distinct disease. It's a unique disease. And it largely, more importantly, is that it largely affects people in their peak productive years of life. So these are the mothers, these are the teachers, these are the household bread earners. So you imagine the socioeconomic impact on the individual or the patient, but also the community and the society. For example, when a 25 or so year old individual is diagnosed with lupus and needs to be absent from work or school or unable to care for her children. So imagine the burden of illness, not just on the patient, but also on the family as well as the community. And add to that the direct cost of frequent visits to a doctor, and they have to undergo tests and take medications regularly. Or worse, even require hospitalization in bad cases. So you have loss of work productivity. You have the burden of illness, not just on the patient, but also on the family and society in general.
Do you have a global idea in your practice of how many patients could not be able to continue working after a couple of years of diagnosis and treatment? Do you have a general idea?
Yeah, in general, there have been statistics that almost like from diagnosis, they lose about 2 weeks on diagnosis. From diagnosis, they do not come to work for about 2 weeks on the average. After that, so you lose 2 weeks of work productivity, and then on the long term, especially for those whose disease is not controlled or those who accumulate damage.
Yeah.
And these patients now eventually need to resign from work
Okay.
or retire early from work.
That's even a major burden socially and economically, both for them and for all the society. And how do you think that the social determinants of health, the poverty, the education, the environmental factors affect both the diagnosis of lupus, the access to healthcare, and even having access to medications like hydroxychloroquine? Is hydroxychloroquine readily available in these
Yes,
countries?
steroids are readily available and hydroxychloroquine are readily available, but there are issues on adherence to both.
Okay.
And the issues and adherence to both, I'll start out with this because, steroids are so cheap and readily available in all countries, and especially in LMICs or low middle income countries. It's actually a wonder drug to reduce symptoms, but then the long-term side effects cannot be overemphasized. For active lupus disease patients, they care more about relief of symptoms than more deeply rooted control of overall disease activity. And this leads to steroid abuse in especially low middle income countries. Hydroxychloroquine, which is also readily available, is only just a bit more expensive than steroids and should definitely be given to all lupus patients unless contraindicated. But that is from the physician's standpoint. From the patient's standpoint, as far as hydroxychloroquine is concerned, it's less attractive than steroids because it's so slow acting. And the steroid sparing benefit is hard to explain to a patient who is suffering from her lupus symptoms. Now, a similar issue with MMF, for example, which is also available in LMICs, a bit quite expensive. But here is where, if you have a relatively expensive drug, here's where prioritizing expenditure on basic needs like food can be more important than spending for medications.
Okay.
And in terms of social determinants, particularly poverty, we know that SLE is a long-standing disease, and in low to middle income countries, we understand that medical expenditures are largely out of pocket. There is no or minimal or very, very limited health insurance. So what's the result? Patients would rather spend their income on basic food and shelter than their health.
Of course.
Now, another social determinant would be education. Per se, in low to middle income countries, we know that the education is a luxury in LMICs. But then we need an understanding of lupus beyond just alleviating physical complaints or symptoms, and which is essential to improve overall outcomes. Let me share two scenarios.
Yes, please.
If you have a lupus patient with little or no formal educational background, in this patient is not likely to take her medications because she is completely asymptomatic, despite the relatively asymptomatic but ominous persistent 2 to 3 plus proteinuria.
Okay.
So that's scenario number one. How can you convince the patient to take her medications, especially medications which are not steroids like MMF, that could spell the difference between long-term outcomes nephritis if she's not feeling anything anyway. And the next scenario, or the other scenario I'd like to share with you, is a patient who does not have much educational background and has a low level of understanding of lupus, continues to take a steroid or
Yes.
prednis, which is cheap. It relieves her symptoms. It's a wonder drug, and mindful of the long-term, usually silent but dire long-term steroid side effects, which are sadly irreversible. And this, we know, adds to the illness burden.
And actually, I would like to add another thing, that is, I'm trying to put myself in that scenario. And if the patient is asymptomatic and living in poverty, and probably that's not a priority, even to go to the outpatients clinic or do the blood tests and travel to the specialized hospital. So probably most of the patients that live in these conditions, they are not even having healthcare or monitoring. So, and that's something that in other countries, it's not the same thing. And the other thing is, what kind of education level is that? Because education is so many things. It's not only going to school and graduating. So even if people go to school, what kind of educations do they have about diseases? And it's completely different from the reality of other countries that are less prevalent, has a population and has a lupus population. So when we talk about in congresses and meetings and with our patients in different countries, higher income countries, when we talk about compliance and adherence to medication, sometimes we are even talking about measuring levels. So what, in your experience, what are the main differences to assess compliance and adherence, and what can we do both for hydroxychloroquine and MMF, for example?
Yeah, we need the education. And as you mentioned, education doesn't require just a degree. It's more of an awareness and an understanding. The challenges here with lupus is that it's not as common as the more straightforward diseases, including cancer. So these are more straightforward. Oh, you have cancer. What kind of cancer do you have? So you have a biopsy and you have a histopath diagnosis. Or maybe hypertension. Okay, this is hypertension. You treat it with antihypertensives. Or diabetes mellitus. You treat it with diabetes medications. As straightforward as that. Or you have infection like tuberculosis. You have a regimen for tuberculosis. So these are straightforward diseases. Maybe common. We can talk about these other diseases like non-communicable diseases, and these are very common and quite straightforward. But lupus is an enigmatic disease. I mean, if you look at statistics, you have a smaller number of lupus among all the diseases. But if you look at the burden of lupus, it pervades many aspects of internal medicine, many aspects of general medicine. Every clinician will, at one point or another, encounter a possible or even potential lupus or a lupus mimicking disease. So that's how enigmatic it is. And sometimes even that thought makes one, a common person, shy away from trying to understand lupus until you are afflicted with lupus. So here's where the education would come in. If you have a patient who has lupus, she has to deal with the disease. So in order to deal with this enigmatic, long-standing chronic disease, she has to understand the disease. And that is where the education would come in. So it's more of disease-specific. What are the potential? How does it affect other organ systems in general? How is it a concern to other physicians other than lupologists? as that is where the education in terms of physician education would come in and patient education would come in. And we talked about adherence. Adherence is important for a patient, and its adherence is much, much better for a patient who understands her own disease than one who is just depending on the prescription of the doctor.
You mentioned that steroids are so much more used both the dosages and the time that they are used, steroids in LMICs, low, medium income countries. And everything that you highlighted as the non-communicable diseases that are the major concern for the country and the patients and all the other physicians are higher, have more prevalence in lupus patients if the steroids are taken. So do you have an idea that what's the scale of these non-communicable diseases like cardiovascular events and mortality, infections like tuberculosis with more steroids, diabetes, hypertension in patients of that come from LMICs?
In LMICs, low to middle income countries, non-communicable diseases actually account for a whopping 80%, average 80% of these NCDs are in low to middle income countries globally. And heart diseases and stroke account for most, for some reason, they account for most of the NCD deaths. And in many of these LMICs, these NCDs actually represent a major burden to individuals, governments, and societies, because they cut lives short. Then they claim people at their most productive age, and they drive individuals to society, to individuals in society into poverty because of this loss of productivity and the need to pay for medications and drugs for a prolonged periods of time. So that's easy to present for non-communicable diseases per se. But then we know and understand fully well that NCDs are also prevalent in lupus and account for most of glucocorticoid long-term side effects. So these are cardiovascular events. So you have accelerated atherosclerosis. They have early onset of myocardial infarction. They have hypertension. They have dyslipidemias, not just dyslipidemias per se, but also because of nephrotic syndrome. And on account of this, they have more strokes, and they have diabetes mellitus, secondary to long-term steroids, and all that. But note that these are NCDs. So the focus is on NCDs per se, but little does the public or those who are not dealing with lupus patients realize that NCDs are so prevalent in lupus, which is why you have to go to lupus. You have to understand lupus.
Yes. And before going to the education part per se, let's just go through something that talking to you, I think it's not as major as education, but the medication access. So some patients do have, they're educated, more educated, they live closer to the lupus centers, and they have the opportunity to be better managed in everything. So too expensive medication like biologics, what is your reality to assess other medications like methotrexate, leflunomide, cyclophosphamide, belimumab, rituximab, anifrolumab? What is your reality in access to medications?
The reality in most LMICs are really, because many of these medications are again out of pocket expenses. They're not reimbursed, and many patients do not have health insurance. So the expense, and we know that biologics, which are the best medications in terms of evidence, they definitely improve outcomes, especially when given early in the disease. And we have all the data to support that. but you have such an expensive drug. So all these biologics are so expensive. So that as far as biologics are concerned, at least I can talk for the Philippines. The only biologics we have are for lupus would be rituximab, which is off-label,
Yes.
and the new anifrolumab. For
Okay.
some reason, belimumab has been removed. Is not available. It's supposed to be available, but for pharmaceutical reasons, I think it has not been made available recently. So
Okay.
rituximab is off-label, but we know it's effective,
Okay.
and we give it because patients. You explained it to the patients. Yes, doc, if only they can afford it.
Okay.
On the
Okay.
other hand, anifrolumab is also expensive, but and that is one of the main obstacles for these patients not having access to biologics is mainly the expense. So
Because
the need for effective medications in the we are working on again education and awareness, especially for public policy
yes.
policymakers. That's so important for them to understand that if you support these medications for our patients, it's society that has the most to gain from this because these are productive patients. And if you treat the disease early, effectively with these biologics, for instance, you're able to prevent the long-term consequences of damage, which can add to the overall burden, like damage in terms of NCDs. So that is how we'd like to simplify how to present this kind of a concept to public policymakers. Yeah, we're currently working on that right now. Cross
Yeah.
our fingers.
Yes. So that's a huge step. That's really a huge
Right.
step. But we would still look at a small percentage of the patients because these would be the patients that would be able to go to the clinics and be monitored and access centers. And we can just rewind a little bit and go for the diagnosis part of it. So before considering any medications, the patient need to have a diagnosis. And this is a small, huge step to improve outcome, because if the delay of symptoms to diagnosis is lower, we know that the prognosis is better. So what is the reality on our mix between the time lag between symptoms and diagnosis, and what is the pathway of a patient in our mix to diagnosis?
Sadly, the diagnosis is long delayed, especially in LMICs, because there's a shortage of lupologists, especially rheumatologists. In my country, we have of 100 and close to 115 million population. There are only less than 300 rheumatologists overall.
Oh, okay.
And among this, we have just less than 30 pediatric rheumatologists.
Okay.
So how do we try to reach that? We have to have a networking with primary care physicians. But even before primary care physicians, what we are working on is a program and an educational module on lupus for the internist. Because we know that lupus is an internal medicine disease.
Yes, of course.
And yeah, and these patients or patients are more likely compared to the general practitioner, for example, who has to handle so many kinds of diseases. So with the additional 3-year residency training for internists, then we feel that at this time they're the most able to efficiently care for patients with lupus, short of the lupologist. So we are reaching out to them and developed a program on lupus for the internist. And it is recognizing lupus early, and recognizing lupus early. So we have internists distributed all over the country. Definitely much, much more. So we have about 5,000 internists all over the country. So if you can reach them, especially in the remote areas, and mobilize them and capitalize on them. So this would be a very important step in terms of lupus education for physicians. The other way we can also reach out to patients in remote areas where there is no rheumatologist is, well, we do have telehealth and teleconferencing. So teleconferencing can be also very useful, and it is inexpensive. It is very cost effective because you don't have to be in the area, and you can just have a teleconference on doing case studies with internists. Discuss and have some kind of a workshop with them via telehealth. The other value of telehealth is that patients who are already diagnosed, you can go on a one-on-one with the attending internist in that remote area, one-on-one, and discuss the case, complications, if there are any questions that they wish to ask on this. So that's a great value of telehealth, which the pandemic has taught us.
Yes, that's what I was going to ask you next. Did you do this? Were you doing this before the COVID pandemic, or it just growth after that, and you just went with the flow of telehealth?
We were not doing telehealth before the pandemic. So it's not routine. So we have paper records, the usual traditional clinics that we hold, and everything was face-to-face. But one of the great advantages, really, or benefits that we had from COVID is virtual conferencing, virtual consults, which is it works both ways. It's a win-win thing. Our patients also do not need to spend to come to the hospital or come to the clinics. They can just go to nearby hospitals or for laboratories, or and we can. And it's very important is the communication that has greatly facilitated healthcare for these patients.
And now we have probably almost 4 years since the beginning of the pandemic. Have you seen differences on the care of patients? Are you discussing more lupus patients? Do you think that they come earlier after starting this education program? It is early yet, but have you seen differences?
It's we don't have the numbers, but from our patient census, at least I can speak from my hospital because it's a training hospital for rheumatology, and the fellows are doing numbers on this in terms of patient census. We seem to have an increase in diagnosis of lupus patients, but we have better ways because we have a growing number of rheumatologists who are spread out throughout certain areas. So this is where we diagnose them, for example, in the institution. They're referred to us by primary care physicians or non-lupus specialists. So yes, so we make the diagnosis, and when we make the diagnosis, we actually send them back to their primary physician, usually an internist, for long-term care. And then we go into a coordinated care, which we conduct via telehealth. So I think it is improving, and I'd like to believe that this has greatly improved the efficiency of healthcare for our lupus patients.
It is really promising, mainly in remote areas. Probably patients will have more adequate, if we can say so, healthcare. And education for patients. We talked a little bit about it, but how do you think involving patients in education you talked about a program with medical students and patients. So I'm curious of how do you think it goes? 'Cause medical students are not as mature dealing with patients as older. It's supposed to be like that. So how do you think it goes with this program with patients and medical students? And theoretically, it's a win-win situation, but how does it work really in reality?
The Patient Partners Program is an educational program for physicians starting, and we had adapted that now to the undergraduate medical student.
Yes.
Well, we in the hope that more of these students will eventually go into internal medicine and learn more about lupus and become, in a way, not necessarily lupologists, but an increasing awareness of why lupus is so important in clinical practice. And it's lupus is a great venue to start off in terms of educating young people, because it's such a fascinating disease. You have different aspects. You can discuss the whole chapters of Harrison's in one patient. Harrison's is a textbook of internal medicine. And I tell that also not just to the Patient Partners Program actually presents. We have actual patients. We have warm-bodied patients who share their stories. These are patients who have been chosen because they can communicate well, because they have coped with their disease well. Yes. So they are able to also inspire medical students to say, look, we need you. We need doctors who are compassionate. We need doctors who are competent in treating us. And this is why we are here, to share our stories and tell you our journeys, so that you are able to understand better the disease and know that it is an important disease. And it encompasses many aspects in medicine. So that is the Patient Partners Program, where you have a patient. We adapted that, and we expanded the original Patient Partners on doing physical examination of joints, rheumatoid, demonstrated by rheumatoid arthritis patients to medical students. And it always, I never tire of having these patients. Even the patients themselves are so enthusiastic about teaching. And I'm humbled by their presence when they are with medical students, because they teach more effectively physical examination of the joints than we rheumatologists.
Yes.
And it's the same thing for sharing stories of lupus, personal stories, the journeys, which can differ from every lupus patient, and especially when they are able now to inspire medical students. It's something that we as faculty, doctors who do not have lupus, do not have rheumatoid arthritis, we can't do. It is the patients. They're more effective in that. And that shows with the feedback that we get from students. So that's as far as the Patient Partners is concerned. Now, what about patient?
Yes, that's what I was going to ask. These patients that are part of the Patient Partner are special patients that were chosen for these. But how does it work with these patients and all the rest of the patients? Is there an education program between patients?
Yes, amongst patients, definitely they need the support amongst them. So you have the peer mentoring, for example. So again, adapted from established studied programs that are already in place in many of the areas, especially in the first world countries. But we have to be creative in our own setting, wherein you have a low middle income country. You have to be creative about how are you going to do this? what is the capability of patients to come, for example, to a forum? Is it going to be face-to-face? Is it going to be one-on-one? Is it small group or big groups? So you have to be creative about that, aside, of course, from the support that we can get from private individuals to support this kind of a program on logistics. But the program is such that a patient who knows that there are other patients who share the same issues and challenges in their journey with the disease, it actually empowers them. It makes them feel better, and it can be therapeutic.
Of course.
So that is where we have patient forums, and the patient forums are actually workshops, and we call them Living Well with Lupus workshops.
Yeah.
And Living Well with Lupus workshops, we're going to handle, for example, psychosocial aspects. So they share, they go into physical aspects and spiritual aspects. So all of these aspects are they're structured. We have a very, very simple structure of how to conduct it.
Okay.
And we have patients. So physicians are just facilitators, but the patients. And here we have our patient partners, so are well with us into this, are actually the one who become their coach. So they're a coach to other patients.
Okay.
It's yeah. So
it seems the right direction. And this would also approach adherence treatment and
exactly. So which cannot be accomplished in a clinic.
Yes, and actually, some studies have shown that peer mentoring is the best way to improve and motivate for adherence, and so it looks really has a good program, and I'm absolutely sure you have successful case studies from these initiatives. And this is the reality that you are working on in Philippines. How do you think that this could be adapted to other LMICs?
So it's collaboration with other countries, in the Asia Pacific, especially in the Asia Pacific. For one, as far as research is concerned, so we have research is concerned, we have the Asia Pacific Lupus Collaboration, or APLC, and that works mainly on developing databases. A database, which is very important. When you have a database of these patients, then you can generate statistics, you can generate numbers, and you can publish them, make publications, and share them with the lupus community globally.
Yes.
So,
and that with policy decisions.
Yes. So that is important for developing policy. Now, the thing with APLC, the Asia Pacific, it's a mix of high income countries and low to middle income countries. So we do have a contribution of that, and even the income level of each country is factored into. It becomes now studied as a variable on what are the outcomes of these patients. So it's a very, very rich area for research to generate all this data and how all these variables can affect lupus outcome. On the education part, we have the Asia Pacific League of Associations Against Rheumatology. So League of Associations for Rheumatology, or APLAR. So this is APLAR. Again, we have the APLAR member countries or member nations, which is also a mix of high income countries, but mostly many of these countries are low to middle income countries. So we share the same issues and challenges and are able now to share strategies on how we can adopt certain programs and learn from each other's programs in terms of physician education and patient education.
Thank you so much, Sandra. This was really fascinating, the work that you are doing with such a challenge in LMICs. Thank you so much for joining me today and sharing your insights into the management of lupus in LMICs. I'm sure we have given our subscribers something of great value here. To our listeners, we hope these discussions have helped you gain more of an understanding of the management of lupus in LMICs. Please download the Lupus Academy 13th Annual Meeting Highlights report from our website. A link can be found in the show notes. You can also view Professor Navarra's on-demand presentations on LMICs on our meeting website until 31st December 2024. Again, a link can be found in the show notes. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.